So is it visible there? Intraoperative cardiac arrhythmia causes and their management. Right.
Yes, sir.
So first, always better to say normal cardiac electrical conduction, how it happens, and then it will be easy for you to describe the various arrhythmia. The mechanisms of arrhythmia are increased activity and circus movement or re-entry. So this is a normal ECG, and these are all the various phases of the myocytes action potential, and the ions and the channels involved is given in this picture. Now, causes of intraoperative arrhythmia are divided into three groups, namely patient surgical procedure and anesthesia related. Now, patient related are elderly patients, existing cardiac disease, intracranial disease, abnormal blood gas and electrolytes. So these patients are more prone to develop an arrhythmia intraoperatively. Surgical procedure related cardiac surgery, because they are directly handling the heart, and dental surgery, strabismus surgery, peritoneal stretching procedures, orifice dilating procedures, MAD like maximum anal dilatation and DNC. So these are all surgical procedures which can cause this problem. The anesthesia agents and endotracheal intubation, and by this group you can remember it can be 5 P's: patient, elderly, history of arrhythmias, pathology, cardiac disease, renal disease, CNS disorder, COPD, electrolyte, position related, prone position, lateral position, pharmacology related, the drugs, analgesic, etc. Procedure related, like even the PA catheter, central venous catheter insertion, ESWL, all these things can cause the arrhythmias. So that is a useful way to describe that. Then how do you identify the intraoperative arrhythmia? What is the heart rate like? What is the rhythm, regular or irregular? Is one P present for each QRS complex? Is the QRS normal? Is there a rhythm associated with hemodynamic instability? And the rhythm, then you describe the commonest thing: sinus bradycardia and tachycardia is the most commonest. Brady is less than 60 beats per minute, and it causes by vasovagal stimulation, hypoxia, hypothermia, endotracheal suctioning, and increase intracranial pressure. And if the patient is hemodynamically stable, you don't have to do anything, just observation is sufficient. But in case it is causing a hemodynamic instability, then you have to go for pharmacological therapy or temporary spacing if it is not getting reverted with that. And the drug of choice for bradycardia treatment is, all of you know, atropine 0.5 milligram is the first line therapy, and it can be repeated every 3 to 5 minutes up to a total of 3 milligram. And chronotropic agents, if it is not responding to atropine, then you can think of agents like isoprenaline, dopamine. And if the bradycardia degenerates into asystole without responding even to that, then immediate cardiopulmonary resuscitation should be started. Now, sinus tachycardia is defined as any heart rate more than 100 beats per minute in the resting stage. And the maximum heart rate you should not go allowed to go beyond is 220 minus age. Where do you use this 220?
In TMT, sir.
TMT, yes, it's Bruce protocol. So this is the maximum you should allow. Beyond that, the patient will develop rate-induced pulmonary edema, because there is hardly any time for the left ventricular filling to occur. So all the blood will stay in the pulmonary circulation. So patient will develop what is called tachycardia-induced pulmonary edema. So the causes of surgical sinus tachycardia are surgical pain, antimuscarinic agent, chronotropic agent, hypovolemic agent, and anesthetic depth. A causative factor: if it is surgical pain, give analgesics. If it is hypovolemia, correct the hypovolemia. If it light plane of anesthesia, increase the depth. So by this itself, we will be able to bring down the heart rate. And if it is still not coming down, then you can use a short-acting beta blocker like esmolol. Then coming to AV block, in the presence of intracardiac disease, perioperative ischemia, or electrolyte imbalance, you may develop this. which are surgical aortic valve replacement. These are all conditions where you can develop a atrioventricular block. Majority of them are transient and do not require any pacing. And it can be the usual first degree, second degree, or third degree. And just make a passing mention of that quickly. And if it requires pacing, escape junction rhythm, and the rate is less than 40, you have to go for that. And the more common arrhythmia you can come across is tachycardia. It is usually at the heart rate PB between 130 to 270 beats per minute, and P wave may be in the classical SVT, you should have a P wave, but sometimes the P wave may be hidden in the QRS complex or in the T wave, and they occurs in excessive stimulation of SA node or atrial excitation. There are four mechanisms by it can happen, and this is the way the ECG will look like, and these are all the mechanisms how they happen. One is called AV nodal re-entrant tachycardia, AV re-entrant tachycardia, and atrial tachycardia. Now all that, the P wave is be seen, sometimes P wave will be not seen, no P, and sometimes P will be seen if it is not getting hidden by the QRS or by the T. And here the acute therapy is vagal maneuvers, adenosine and verapamil. Chronic therapy, if it is even present in the pre-anesthetic stage, then they will be in the chronic usage of verapamil and diltiazem, beta blockers, or class 1C or 3 antiarrhythmic drugs could have been taken. So it's a common treatment for all this. Then atrial flutter and fibrillation are other common things that can happen. Flutter is a regular rhythm, regular PQRS will be there, 2:1 or 3:1 ratio with the normal QRS. Heart rate will be around 250 to 300. And it will be the classical sawtooth pattern, which is also called the F waves. So this is how the P wave will look. Then a QRS complex will come. So it can happen after 3 or 2 P waves and then one QRS complex. And this is synchronized cardioversion is the treatment for that. And atrial fibrillation is excessively rapid, all of you know, and it can happen because of the so many like Matty Snows is the commonest pathology that we come across, thyrotoxicosis, alcoholism, already present ASD, COPD patients, infection, hypertension, ischemic heart disease. These are all the causes for an atrial fibrillation to occur. So if you are dealing with a patient with thyrotoxicosis, you have to anticipate AF. And similarly, COPD patients, suddenly they can develop AF. Or a known ischemic hypertensive patient, you have to anticipate AF. So it causes an irregular pulse with a pulse deficit. The loss of atrial kick causes a possibility of atrial thrombi with the resulting pulmonary and systemic thromboembolism. And it has to be controlled by rate control with beta blocker or digoxin, rhythm control by cardioversion, and anticoagulation with warfarin and heparin. So if it happens, if it is less than 48 hours, you can definitely blockers and cardioversion. But if it is more than 48 hours, first you have to start anticoagulation and then only go for the rhythm restoration. So premature ventricular contractions are also irregular, and they are arising from the ectopic pacemaker areas, and if they have a wide bizarre QRS pattern, and it is frequently observed during anesthesia. This is one of the commonly seen. Its clinical significance is limited, and a new onset premature ventricular contraction should be considered due to myocardial ischemia, which may lead to VT and VF, VFib. So, if it is occurring frequently, then you have to have the suspicion of myocardial ischemia. And ventricular tachycardia, heart rate will be 100 to 200 in tachycardia, and it will be regular. That is the beauty of that. And P and QRS have no fixed relationship because of atrioventricular dissociation. And the treatment for that is amiodarone, loading dose, and then followed by 6 hours one dose, and then 18 hours another 0.5 milligram per kg. And synchronized conversion can be applied if it is causing hemodynamic instability. So for all arrhythmias, first you have to see whether the patient is hemodynamically stable or not. I'll show you a flow chart how to go about that. And you have to use this much of strength, 200 to 350 joules. And magnesium sulfate may be helpful. Epinephrine may sometimes, if you are going to do the correction for fibrillation, it may convert the fine fibrillation into post fibrillation, which will make it easy. So format that you see in the ECG, a regular bizarre white QRS. Whereas once it turns into ventricular fibrillation, it becomes irregular like this with this thing. And the one type of ventricular fibrillation is torsade de points, which is having a prolonged QT interval, or bradycardia cases will develop into that. And so you have to check the baseline QT interval and check for whether the patient is taking any drugs which will prolong the QT interval before surgery. And the first line of treatment for this is magnesium sulfate. So even though it is a type of ventricular fibrillation, you don't immediately revert it by defibrillation. You go for magnesium sulfate, and this is how the whole thing looks like. And there is another thing called pulseless electrical activity. This also you have to mention in your description. The life-threatening non can be differentiated only by the ECG, and this is how the ECG will look. This is a normal ECG, and in pulseless electrical activity, you get a regular complex like this. But when you palpate or auscultate, you don't hear a heartbeat or you don't hear a pulse rate. I mean, palpate pulse. So the causes are, it can be 4H and 4P. These are all the common causes: hypoxia, hypovolemia, hypothermia, hypokalemia, and toxicity, tamponade, tension, pneumothorax. So once you make a diagnosis of PEA, a specific treatment for the particular condition, and then you can, the first drug is adrenaline 1 milligram every 3 to 5 minutes along with CPR. So these are the common antiarrhythmic agents that are used. This is for your just knowledge of the theory, and they are based on the receptor channels. So class 1A is acting on sodium potassium channels, 1B on sodium channels, and they are all sometimes they say 1C is also there, and they all act mainly on sodium channels, and 1A has got a very strong action, moderate action, and weak action. That is how it is classified. And class 2 drugs are beta adrenoreceptor blockers. Class 3 drugs act on the potassium channels, and class 4 drugs act on the calcium channels. So they mainly act on the ion channels, and that is how their action is there. So the reversible causes of supraventricular tachycardia and non-sustained ventricular tachycardia are of course very common things, hypoxia, hyperthermia, etc. And there can be artifacts which can mimic important practical things that you should remember, and that may be misinterpreted as a atrial fibrillation or a ventricular fibrillation. And this is how do you differentiate that? You check for the patient's vital signs, particularly arterial pulse and arterial blood pressure. And if they are found normal, then you can say it is artifact. So this is how it will look like. Looks like doesn't fall into any particular category, but you see a QRS top R wave is there, then it goes bizarre. So this is practically a good example of a artifact. So how do you proceed when you have an arrhythmia? First check for the pulse. Pulse present, yes means then look for the hemodynamic status. If pulse is absent, that means it is either a PEA or a cardiac arrest. Straight away go for CPR and this. If the pulse is present, then look at the hemodynamic status. If it is stable, see whether it is bradycardia or tachycardia. And if it is bradycardia, check for the need for pacing or whether it can be corrected with the atropine and other drugs. If it is tachycardia, see whether it is a narrow QRS or a wide QRS. And if it is a narrow QRS, whether it's a regular or irregular narrow QRS. If it's wide, whether it is again regular or irregular. If it is depending upon that, the drugs of choice are adenosine beta blocker or calcium antagonist amiodarone. And if it is wide complex, again adenosine, amiodarone, procainamide, and sotalol. And if it is irregular, you can go for amiodarone DC conversion or procainamide. And if it is hemodynamically unstable, if it is bradycardia, of course, if it is tachycardia, synchronous conversion. So this chart is very easy to remember and then describe all the various things. And this is another one to decide. Identify and treat the underlying cause, persistent bradyarrhythmia causing hemodynamic instability. Yes means atropine, dopamine, same thing in another flowchart form. And persistent tachyarrhythmia. This is mainly between tachycardia and bradycardia cases. Synchronized cardioversion, white QRS, vagal maneuvers, pharmacokinetic therapy, consider all these things. So these two pictures will help you to remember about the various ways of managing and writing about the arrhythmias. So that way you can save the time by putting this chart in a fashion so that simultaneously covered also. Okay.